Hello, everybody. Welcome to Exercise and the Brain. We're going to cover a lot of conditions and situations that involve the brain and/or neurological system in this lecture. So exercise in the brain is probably no surprise that brain health is the optimal or maximal functioning of behavioral and biological measures of brain and the subjective experience arising from brain function, such as mood. And the 2018 Physical Activity Guidelines scientific report concluded that there is unequivocal evidence that exercise influences brain health and that individuals with conditions that affect brain health could greatly benefit from engaging in exercise. So this semester, we've seen how exercise is good for a variety of people. So it's no surprise that for a lot of people with neurological differences also benefit from exercise. And exercise is beneficial to the brain because it decreases feelings of depression and anxiety. It improves focus, concentration, reaction time. It can promote the growth of new brain cells. It can protect against aging-related brain diseases, such as Alzheimer's disease. So the first thing we're going to talk about with the brain is ADHD and exercise. And the 2018 Physical Activity Guidelines Advisory Committee said that regular physical activity improves attention and inhibition, both critical dimensions of ADHD. And they strongly support the use of physical activity to improve attention. Impulsivity is another core symptom of ADHD, and there's also evidence to support a link between engagement in physical activity and improvements in cognitive inhibition. When we talk about ADHD and exercise testing, the modifications we have are focused mainly on exercise testing in children and adolescents. There's not a lot about how we would modify for adults with ADHD. It's just not a very large area of research. So most of the stuff that we have is related to children. And the most updated and evidence-based health-related fitness test battery is the European Union-funded Alpha battery. In most cases, individuals with ADHD can start a moderate intensity exercise program without medical screening. So remember, we do exercise testing for two reasons. One, because we want to do their exercise prescription, and then two, if it's recommended before they get an exercise prescription. So if we're doing a cardiac stress test and whatnot to make sure that their heart is healthy, or if we're doing balance tests, we'll talk about that later in this lecture, to make sure that exercise is safe. That's another reason to do exercise testing. So both individuals with ADHD can start exercise without needing medical screening. If ADHD is presented with comorbidity, so there's other conditions in addition to ADHD, exercise professionals should review relevant exercise testing options as listed elsewhere in the ACSM guidelines. So for example, if you have somebody with ADHD and a cardiovascular condition, you're not going to say, oh, well, ADHD guidelines say that we can do moderate exercise without any problem. You want to look at the one that's most conservative. So you look at the cardiovascular disease guidelines. So in children, this alpha test battery that we're referring to has several things. It has pubertal stage, which normally we wouldn't do. That would be something that their clinician would do and relay the information. BMI, waist circumference, skin fold thickness, all this to assess body composition. Hand grip strength for musculoskeletal fitness, standing broad jump for fitness as well, 20-meter shuttle run to assess cardiorespiratory fitness, and a 4x10 shuttle run to assess motor fitness. So most of these, except for that motor fitness, are typically done in children anyways. If there's, when time is an issue, or if they're just interested in the health-related testing, then we rule out this Tanner stage and rule out. We don't do the Tanner stages or the 4x10-meter shuttle run. And just for comparison, little party hat, you're not going to need to know this. There is also an alpha test battery for adults, and it is different. It's tests that are more applicable to adults, whereas the other one is more for children. So brain health and exercise is still a relatively new area of research for most of these neurological conditions we're going to talk about, one of which is ADHD. And this study was pretty interesting. I'm sorry, the next one's pretty interesting. This one's just, this leads into the one that's pretty interesting. All right, so this is a meta-analysis. With meta-analysis, I want to talk about this. Um, Data is pooled from other smaller studies to make one large study. And this provides more statistical power to the topic and can sometimes provide more information on the topic. And they don't just pick all, so for this one, they didn't pick all studies of exercise and ADHD. They have specific criteria. So usually they're looking for a certain age range, certain tests that were done before and after the exercise intervention, maybe an exercise intervention that's of a certain length. And so that's where they how they decide on which ones they're going to use. So in this one, and a lot of times you end up with these plots here where each individual study is a line, and then this diamond here at the bottom is sort of the, I'm going to say average. It's not a real average, but it's kind of, let's just say all the studies together, what they're pointing to. And so usually this looks at if it favors the control group or favors the experimental group. And so looking at hyperactivity symptoms, there's a slight favor for the experiment group over the control group in these studies that they used. And something else I looked at in this was depression. And this is flipped, the axis is flipped here. But again, the improvement in depressive symptoms in kids with ADHD favored the experimental, the exercise interventions. And there was a bunch of other things they looked at too, but these were just two things I was pulling out. Oh, excuse me, I got three things. I forgot to pull out another one, which is motor skills. And again, experimental can favor experimental group. And I know I said there was two. I updated this lecture. There used to just be two, and I added two more because I thought these last two were interesting. So this really is the last one. So executive function, and there's a lot more studies on this. Again, it favors the control. It favors the experiment group as well. So exercise improved hyperactivity symptoms, depression, motor skills, and executive function. When they pulled all these studies together, they're able to see have evidence to support these. Right. And then this other one, this one is really interesting one. I want to talk about it for a couple of reasons because I think it's something we need to think keep in mind sometimes when we are thinking about our exercise and reading these studies. So in this one, they had a randomized controlled trial of exercise for ADHD and disruptive behavior disorders. This was a 10-week after-school program in kids grades K through 8, and they said it was in a high poverty school. This might be a school where there's not a lot of opportunities for the kids as far as enrichment. And in the study, there was 86% retention, meaning that 86% of the kids that started it ended it. There was 60% attendance at the sessions, and the average heart rate in the exercise group was 75% of max heart rate during the exercise. And a little bit more about the study design. So this was pretty interesting. They had all the kids, regardless of what group they were in, they all had a 15-minute stack. So it was after school. They had their snack and they transitioned. They had 45 minutes they worked on homework. So there was college kids, I believe, that were mostly college and both undergraduate and graduate who were leading this intervention. So they helped the kids with homework for 45 minutes. And then they had a 15-minute transition to their intervention group. And they either had structured physical activity or sedentary play. So for the physical activity group, this meant they played games, they had sports, they were heart rate monitors. And I thought this was a really interesting way to get kids to motivate kids to do exercise was they gave them tickets, like tokens, if they, it would be based on where the heart rate was. So if they got their heart rate closer to the zone that they wanted the kids in, the higher activity, it's in a higher heart rate zone, then they got 2 tickets. And they were the lower end of the zone, they got 1 ticket. And they had prizes the kids could purchase with the tickets that they earned. The sedentary play group, which is like what it sounds like, they were playing, but it was things that are more sedentary. So art, Legos, puzzles, board games. And the kids also earned tickets, but it was obviously not based on heart rate because it was an exercise. It was based on participating in the actual activity, using the supplies correctly, cleaning up the area, things like that. So all the kids had an opportunity to earn these tickets. All right, so I'm going to ask you a question. That's all I've told you about the study so far. What do you think? Where'd it go? What do you think the results were for this? Do you think that, so we had that control sedentary play and we had the the exercise, but all the kids had that first hour that was the same, the snack time, the homework help, and the transition to their activity. All right, well, this is what was made this super interesting to me, was that regardless of the group they were in, if they were in the control groups, that was that sedentary group, or the physical activity group, they all had improvements in their inhibition. They had improvements in, and this was, so they had neurological tests, they had parent reports. And based on the parent reports also, they had improvements in inattention severity, hyperactivity severity, social skills, problem behaviors, all of this was improved in all the children, regardless of what group they were in. So at first you're kind of like, well, the exercise didn't really work. Well, we can think about it another way, right? So there were substantial improvements in both groups with a near zero effect size difference between groups on the primary executive function outcome. So I didn't talk about effect size, but basically the larger the effect size is, the more effective, like it says, the treatment was. This is a really quick summary of this, really basic summary about this. I'm married to a statistician, by the way. He would probably, if he heard me saying this, he'd probably correct me and add more details, but that's basically what we need to know, right? So it wasn't that one group had a bigger effect than the other. Not only were both groups had significant improvement, but it was a significant, excuse me, it was a similar effect that both groups had. So it wasn't really like one group was better than the other. And everybody, all the kids had low executive function at baseline. And also, it was interesting, they made a point about this, is that with proper training and support, undergraduate and graduate students can implement high quality after school physical activity programs for children with behavioral disorders in a high poverty community. Children in both groups improved on clinically relevant outcomes. So again, there was no difference in these outcomes whether the kids had the structured play or the physical activity. And we know both these things are important for kids, right? We know that they need physical activity and we know that structured play is important. And then what they didn't talk about earlier in the conclusion was that first hour where all the kids had the homework help and the snack and the support to after school to get this stuff done. So I don't think we should be choosing necessarily between exercise and sedentary tasks, but of course, why can't we have both, right? Recognize that maybe we have goals for the kid with exercise, but we also have these goals with them with their playtime, their structured play. Right. For ADHD and exercise prescription, we have a few considerations. Low fitness is common in ADHD, so we're going to want to start slow and set realistic goals. Developmental coordination disorder is frequent in people with ADHD. So there's a couple conditions we'll talk about today, one of which is ADHD, where it's common, especially in children, that it co-presents with other disorders. And whenever possible, should train in small groups. Now, we don't mean small groups instead of individual one-on-one. We mean small groups instead of larger groups. So, 4 to 5 versus 20. And the shorter duration and high intensity of HIIT may be beneficial for exercise prescription in people with ADHD. Some special considerations. Physical activity will be complementary to pharmacological treatment. There's no evidence that exercise takes the place of pharmacological treatment in ADHD. And it's beneficial to create exercise sessions that include structured, previously planned, and part of a routine. Have defined specific measurable daily goals. Everybody likes that anyways, right? Include program variety, including functional movement patterns, also good for a lot of groups, and is done in a group setting. Moving on to Alzheimer's disease. This is the most common cause of dementia. 60 to 80% of all dementia cases are related to Alzheimer's disease. And Alzheimer's disease is characterized by progressive declines in learning and memory. And this is followed by more severe declines in cognition, mood, and motor abilities. Alzheimer's disease is currently the 6th leading cause of death in the United States. This number of cases is expected to double by 2050. And the greatest risk factor for Alzheimer's disease is age. So far as exercise testing goes, it's going to be dependent on the stage and severity of the disease. Late stage Alzheimer's is going to be very difficult to do an exercise test on. And this is going to be more if there needs to be additional screening for like cardiovascular disease as opposed to us for exercise prescription. We would probably do pretty simple measurements for this if we did decide we need to do any at all. It's recommended that all exercise testing be conducted in consultation with a physician and or neuropsychologist. and it should take into consideration any comorbidities. High intensity exercise testing can be safe, and it may be recommended to use cycle ergometry instead of a treadmill, depending on what the reasons for the testing. Exercise testing is contraindicated, so not recommended, in conditions of severe memory loss. And standard measures of exertion, such as the Borg scale, may be invalid in cases of severe Alzheimer's disease. Strength testing is possible in people with Alzheimer's disease, especially in cases of disease. So some exercise considerations. Whether an individual can perform exercise activities on his or her own depends on the severity of the disease. Metabolic, cardiovascular, joint, and muscle atrophy comorbidities may restrict the frequency and duration of exercise. It may be appropriate to start an exercise regime with short bouts of 10 minutes or less. Once acclimated, long, continuous bouts of exercise are more likely to be helpful in preclinical and early stages of the disease, yet less likely to be feasible during later stages of the disease. Some other special considerations. In the early stages of Alzheimer's disease, independent and community-based exercises are encouraged. Training and exercising the caregiver to help provide support, motivation, and monitoring of safety may be beneficial. Morning exercise may be easiest, and most beneficial when individuals demonstrate the lowest severity of symptoms, oftentimes in the morning. And even if the person is no longer living at home, if they're in a nursing home, memory clinic, or senior care facility, exercise is still encouraged. This is, again, assuming that the staff is properly trained to monitor the individuals and have the individuals be safe. Anxiety and depression is another area where exercise may be beneficial. Submaximal exercise tests are highly recommended due to poor physical health and fitness level, low physical self-worth, and limited motivation for maximal physical effort. So this is a submax test as opposed to maximum test where somebody's going to have to be motivated to do a lot of effort, or where, the fitter you are, the easier it is to do a max test. Pre-test anxiety can also influence testing results due to fears of physiological reactions, which mimic physical symptoms of anxiety and depression. So, for example, shortness of breath, chest pain. Some of these symptoms can mimic panic attacks. And it's important to screen for medication use, as some medications may cause drowsiness and poor coordination, as well as reduce the plasma catecholamine response to exercise. So let's look at some studies here. The first one, the effects of a moderate physical activity intervention on physical fitness and cognition in healthy elderly with low levels of physical activity, randomized controlled trial. So in this one, it was a 9-month intervention. That's a pretty long intervention. Good for them. And they looked at the ability to perform the timed up and go test. You're going to do that in lab, and within 20 seconds or less, and a mini mental status examination, MMSE, score of at least 25. So this is, it asked questions like what day it is, it has people count backwards, it has them spell some words, recall items. There's a bunch of questions. You can look it up online. And they had this 2-to-1 exercise training intervention that they had the acronym of COACH. It was pedometer based, 7 sessions with the coach, or stretching. And the results was that in the timed up and go, which was their main outcome for this, that in both the men and the women, the group that was receiving the exercise intervention improved their timed up and go times, whereas the group that was stretching did not. So the point of me showing you this particular study was just to get at that adults with some cognitive impairments can still improve their physical fitness. So even if we're not improving their cognition, if it's advanced stages of disease, we can still improve their physical fitness, which will hopefully help with other tasks overall. This should have been before I started depression and anxiety. I don't know how it got mixed up in here, but we'll switch back to anxiety and depression with this next slide here. All right, so exercise testing. Some maximal exercise tests are highly recommended, again, because of poor physical health and fitness levels, low physical self-worth, limited motivation for maximal physical effort, and screen for medication use. All right, I see what happened. I rewrote these slides. These are a little better than those first ones I presented, and then somehow they didn't get deleted. They got inserted there. All right. So individuals with anxiety disorders have had mildly impaired blood pressure responses to cardiovascular exercise and should be screened prior to exercise testing. Same thing with individuals with generalized anxiety disorder have elevated worry and poor vagal tone via heart rate variability, which could negatively affect exercise testing. And women with anxiety disorders, but who don't have coronary artery disease history, still have an increased risk of ischemia during exercise testing. This is why it's important to know people's history. So specific to anxiety, exercise is effective for reducing anxious symptoms, and this applies to people with and without anxiety disorders. In individuals with clinical anxiety disorders, exercise is effective for reducing symptoms both in combination with other treatments and in comparison to non-active control groups. And exercise is effective for reducing anxious symptoms, and this applies to people with and without anxiety disorders. So in general, meeting the recommended physical activity recommendations is appropriate for reducing anxiety. The fit for people with anxiety is similar to what's used with most adults. There is some evidence that suggests higher intensity exercise has greater effects on decreasing anxiety. But exercise bouts of at least 1 minute are beneficial. And both aerobic and resistance exercise training appear to be effective for reducing symptoms of anxiety in healthy and clinical populations. Oh, I missed the CR either. I have it left in the aerobic. The ATSM books, a lot of times we'll switch to aerobic if I try and switch that out for us in this class. All right, exercise is effective for reducing depressive symptoms and people with and without clinical depression. So again, and if somebody's not diagnosed as being actually clinically depressed, if they're just feeling a little low, exercise can help. Exercise is also more effective for reducing depression than bright light therapy and other controls. So when they compare exercise to a control situation like bright light therapy, the exercise group improves more than the bright light therapy group. Even though I said exercise is good for people with depressive symptoms, whether or not they are clinically depressed or not, the effects of exercise seem to be more profound if the person is clinically depressed. And in individuals with depression, aerobic exercise has proven to be as effective as psychotherapy or pharmacotherapy for reducing depressive symptoms. Now, we're not saying somebody should stop their medications and start exercising, but it may lead to improvements where they can reduce their medication or stop it after they've consulted with their care provider. As far as our prescription, FIT applies similar to that for most adults. Cumulative frequency of exercise matters. Programs lasting at least 13 days consistently reduce depressive symptoms. So it's probably not going to somebody exercise 1 day and then they feel great. It's going to be cumulative. The more days they exercise, the better they're going to feel. Any intensity level seems to be effective, and 20 minutes appears to be enough for those who have depressive symptoms but not a depressive disorder, whereas if there is actually clinical depression disorder, then 45 minutes, a little longer exercise is needed for a benefit. And again, both mixed aerobic and resistance training programs appear to be effective, or excuse me, both of them together appear to be more effective than one alone. And the last slide here, just a reminder to touch on this a little bit earlier, individuals with known panic disorders should be advised to expect panic-like symptoms as a normal result of exercise. So what are some signs of panic? What are some panic-like symptoms? Things like shortness of breath, increased heart rate. What happens when we start exercising? We have a shortness of breath or feeling of shortness of breath and increased heart rate. So just a reminder that that's normal and it's not related to their panic disorder or panic symptom, but it's just a normal expectation of exercise. And if you can give a new guideline like, oh, we're going to watch your heart rate go up to this and whatnot, that might be helpful for some people. Some exercise is better than none for reducing anxiety and depression, and meeting recommended levels of physical activity has the best results. So that 150 minutes per week of moderate or 90 of 60, 90 of vigorous. For individuals with depressive disorders, reduced sensitivity to rewards can create additional challenges for adhering to physical activity, right? So again, if it affects motivation. And individuals with depression or anxiety can benefit from supplementing exercise with support for self-regulation. The next neurological condition we're going to talk about is autism, and there's going to be more research on this. ACSM certainly has a little focus on autism with certificate you can get on exercise training for people with autism. So in general, exercise is safe for populations with autism spectrum disorder. Pre-participation health screenings follow general recommendations. It's not a one-size-fits-all testing plan, so consider visual schedules, social narratives, task analysis, prompting, and reinforcement to assist kind of what based on the person is. And you know, I'm going to use the language that ACSM and the studies I referenced use, but some of this is changing and evolving a little bit faster than the materials can keep up with. All right, so autism exercise prescription, children and adults gradually progress to a fit similar to children and adults without ASD. Activities of all types can be implemented for individuals with autism. However, those with motor deficits may benefit from starting with type A and B activities. I'll remind you what those are on the next slide. Type D activities inherently involve the use of social and communication skills, and it offers opportunities for the cardinal features of autism to be improved on. So A and B, these are our general movement activities, endurance activities with minimal skills, whereas D are recreational sports. So start out with the A and B, and then we can progress to D if the person's ready. Autism and exercise prescription, fit recommendations hampered by large variability within the intervention studied among individuals with autism. So this makes sense, right? If we have, even though this might be one condition, you know, like with Alzheimer's, there can be a wide range of symptoms and severity of the disease and what the person is able to do. And it is still a relatively new area of research compared to other populations. You know, just like there's not one exercise prescription for cardiovascular disease or obesity, there's also variability, so it is this one. But it is important to keep in mind that approximately 1/3 of individuals with autism also have some form of intellectual disability. So it's something that co-presents with other conditions as well. Actually just one study I'm going to show you. So this one has a combined physical training strategies improve physical fitness, behavior, and social skills of autistic children. These kids were 6 to 10 years of age. There's an intervention group and a no treatment control group. There's 3 sessions per week for 8 weeks. This paper's kind of vague, so not a lot of details about that. But the exercise was ball games, rhythmic movements, and resistance training. And mainly what I wanted to point out was that there was a significant effect of the exercise training. That they improved fitness, strength, power, flexibility, balance, and agility. There was also improvements in stereotypic behaviors, communication, and social interaction. So not only was the physical activity related metrics improve, but also these other measured items. Right. And the conclusions for this was that short intervention time may have limited fitness improvement. So there wasn't huge improvements in fitness, but it was 8 weeks. And limited resource physical activity interventions was successful at improving fitness, behaviors, and communication. Right, so ACSM has, like I said, quite a bit of resources about autism. And one thing they point out is that there's a lot of things that have been successfully implemented in the classroom, but rarely implemented in the gym. So fitness professionals who work with children with autism should be educated on how to improve based on these evidence-based practices, all right? So we can learn from what is used in the education settings. ACSM has this interesting blog post where parents that were surveyed rated exercise as the #1 treatment for autism. One common thing heard from parents is my child is no longer involved in occupational physical therapy, so he's not moving as much. What should I do? So this may be with kids with autism or without, but they kind of graduate. Sometimes that's kind of hopefully the goal in some situations to improve so much that you don't need the therapy anymore. And so ICSM has some great handouts, and they have these top 3 evidence-based practices for exercise programming in autism. I know it's a small, we're going to take them one at a time. So the first one is to use visual supports for increasing engagement. So pictures, written words, visual schedules, checklists, which really, I've talked about this, I think, before. If not, then I'll talk about it now. A lot of times things that we develop specifically for a special population is actually helpful to a lot of people. And so that can help with audience. Like if it's, why are we developing this first? We have a small population. It's like, well, the population in general will also be interested in this, right? Most people want checklists for their exercise, right? They want some visual representation. If you tell somebody, I want you to do these neutral grip bicep curls and a goblet squat, that doesn't mean much to them. But if they have pictures or GIFs and stuff for how to do that, then that's very helpful to them. So again, we can increase marketability or increase people wanting to develop this because it is applicable or interesting to its use for a wide range of people. All right, so for example, there's this thing called Exercise Connection, and it has pictures and a timer to help with the exercise. There's this paper-based one where it has the exercises that you can do with that. So there's lots of options for that. Another one, video modeling for quick exercise skill acquisition. And so this can reduce the amount of verbal instruction required. So instead of having the person having to listen to the cues, they can watch the cues. Again, like video feedback. And of course, reinforcement for success. Who doesn't like that? So positive reinforcement with verbal praise. And to remind that your client's persistence, not perfection. I've also heard it as your progress, not perfection. So in summary, our FIT PV is going to work toward goals for age group. It's a population that may be more conditioned. So again, they may co-present with other diagnoses, so need to go low and slow in that group. All right, let's move on to our next one. Oops, Parkinson's disease. So this is a brain disorder, and it causes unintentional or uncontrolled movements such as shaking, stiffness, and difficulty with balance and coordination. It can also lead to mental and behavioral changes. And there is a gradual worsening of symptoms. The rate at which it worsens varies between people, and some forms of Parkinson's disease may be genetic. So a quick little reminder of our brain. I'm going to point out where we have our basal ganglia here, kind of in the center-ish of the brain. This is what's affected with Parkinson's disease. This is the area of the brain that controls movement and produces dopamine. In Parkinson's disease, the neurons in this area die, and it's unknown why at this time. And people with Parkinson's disease also lose the nerve endings that receive norepinephrine signals. So it's important for our sympathetic nervous system response, right? There are four main symptoms of Parkinson's disease: tremors in hands, arms, legs, jaw, or head; muscle stiffness, where the muscle remains contracted for a long time; there's a slowness of movement; and there's also impaired balance and coordination, sometimes leading to falls. Other symptoms may include depression or other emotional changes, difficulty swallowing, chewing, and speaking, urinary problems or constipation, and also skin problems. So there is a bit of changes with the, like I said, with the posture, which may affect our exercise prescription, what we're going to recommend for the person to do. There's a tendency to lean forward, to take quick, small steps, and to have a reduction in swinging their arms. And here's one figure with that about how someone with Parkinson's disease posture and gait tends to change. And I found this other one too, which I thought was interesting. It had this acronym TRAP about the symptoms, and then it also had the accompanying figure about the gait changes. The interesting thing about Parkinson's disease, and one of my favorite clients I had when I was training had Parkinson's disease. He was really fun to talk to. He would come in with his caretaker and train him, and the client would say something like, "I did 75 push-ups this morning," and his caretaker would be like, "All right, what morning was that?" "This was back in 1943 when I was living in Chicago." And I don't know, he was just fun. But what the really interesting thing, getting back to this with people with Parkinson's disease, is that they have this this shaking, these tremors and whatnot. But while they're doing the exercises, it tends to go away. So I like using stacked weight machines for people with Parkinson's disease because a lot of it is sitting, so we don't have to worry about their balance or their gait. And then they're on a track with the movement, right? Like they can't accidentally drop a weight or do a movement that's going to cause them to get injured. Or at least it's a lot harder to do that on a stacked weight machine. And so, like I said, the interesting thing is that while they're doing the exercise, that tremor seems to go away. So it's just an interesting disease. Not always in a good way, but it's interesting. Exercise does seem to be helpful. So there's treatments for Parkinson's disease currently. There's medications to increase dopamine, physical, occupational, speech therapies, of course, healthy diet to support overall wellness, exercise to strengthen muscles and improve balance, flexibility, and coordination, massage therapy to reduce tension, and yoga and Tai Chi to increase stretching and flexibility. ACSM has this common movement disorders in individuals with Parkinson's disease. So this is just what we've been talking about, just in one little box, as you might see from ACSM. The treatment includes drug therapy, surgery, exercise included in treatment. So for exercise, ACSM says that for people with Parkinson's disease, exercise is a vital component of managing the signs and symptoms of the disease. It can decrease or delay secondary effects of Parkinson's disease that affect musculoskeletal and cardiorespiratory symptoms, can reduce disease severity, it can slow down the progression of the signs of Parkinson's disease, and of course, improve strength, aerobic capacity, gait performance, and quality of life. So again, if somebody's having trouble with lifting their feet or shuffling a little bit, the stronger they are, the easier it is for them to try and have a corrective movement. ACSM has some additional considerations for people with Parkinson's disease. Most individuals have impaired mobility and problems with gait, balance, and functional ability. Most are older and have reduced physical activity levels, so the assessment of cardiovascular risk may be warranted. Autonomic nervous system dysfunction can occur. This can present as blood pressure abnormalities, including orthostatic hypotension, so changes in posture causing hypotension, and so getting lightheaded if we do quick posture changes, especially from sitting or laying down to standing up quickly. If a graded exercise test is conducted, ideally should be when anti-Parkinson medication is at peak effect. So what kind of tests do we want to do? We want to do balance tests, functional mobility test, timed up and go, and gait, 10-meter walk test. I think we do 10-meter walk tests in lab too. We used to do it when we switched labs from 90 minutes to 1 hour, but that one may have gotten dropped. But it's just like it sounds. They walk 10 meters. Skeletal muscle strength test, arm curl test. We do that in lab. 1RM assessments or 8RM assessments, dynamometers, chair rise tests. We do those in the lab. Flexibility can be assessed with goniometry and the back scratch test. And for aerobic capacity, it's recommended to do the 6-minute walk test. And my little note right there is that one advantage of the 6-minute walk test is that you can do a gait analysis at the same time. In the early stage of disease, the treadmill may be safe. Severe gait, balance, impairment, or history of falls, cycle ergometry alone or in combination with arm ergometry. In advanced cases or severe mobility and impairment, we're definitely going to do submax tests, not max tests. And a gait belt should be worn, a technician close by if lower extremity weakness or history of falling. So that might not be you, that might be their caretaker or somebody you're working with. If you're going to PT school, then of course you were trained to do a gait belt. Same as a fitness trainer, we might not be trained in that. ACSM has this nice little fit table with recommendations for exercise. So it's pretty similar to other older adults, right? 3 to 4 days a week of cardiovascular fitness, 2 to 3 days of resistance, at least 2 days a week of flexibility, and then it adds this neuromuscular column. So I mainly want to show you this to show that it has this added, I said neuromuscular, excuse me, neuromotor column. So there's a little less time on the cardiovascular fitness, but they've added this neuromotor column. So balance, motor skills, so forth. ACSM has some recommendations. They have a handout for people with Parkinson's disease. And I'm just going to blow through these. I'm mainly just showing this to you. And it has, this is a handout to give people with Parkinson's disease. It gives them exercise prescription advice and whatnot. It has some tips on it, and it mentions it's different than some of the other ones that ACSM puts out because it has this balance and coordination part as part of it. The last thing we're going to talk about with our neuromuscular and brain is multiple sclerosis. We're going to talk about this because it's the most common disability neurological disease of young adults. The average typical onset is between the ages of 20 and 40 years of age. And the immune system attacks the myelin and the central nervous system, so the brain, optic nerve, spinal cords. And as a reminder, the myelin sheath is what protects and coats the axons and nerve fibers. So we have our nerve fiber here, and up near the neuron, supposed to be kind of like a typical myelin, healthy. And then down here we have one where the immune system has started to destroy it, which means the nerve signals are slowed or blocked, and this is what causes the MS symptoms. The signs and symptoms of multiple sclerosis varies greatly from person to person. There's 4 types based on progression of symptoms. And early symptoms frequently include vision problems, muscle weakness, tingling, numbness or pain in the arms, legs, trunk, or face, clumsiness, especially difficulty staying balanced when walking, bladder control problems, and intermittent or constant dizziness. Treatments include corticosteroids, plasma exchange, monoclonal antibodies, and oral treatments, so prescriptive medications. As far as MS and exercise, there's little research, but it's generally encouraged. We do have to worry that exercise or the person may have fatigue, weakness, poor coordination, sensitivity to heat, which would affect exercise. So exercising indoors where there can be air conditioner or fan may be better for some people with MS. Exercise is beneficial because it can increase strength and balance, improve bowel and bladder control, and decrease spasticity. But we do need to take an individual approach. So there's several types, there's several symptoms. Where is the person in this when doing our exercise prescription? And there's a note from ACSM that exercise and water may be especially beneficial. ACSM does have this fit recommendation for individuals with multiple sclerosis, and they recommend cardiorespiratory fitness, resistance, exercise, and flexibility as well. So you'll notice that these are pretty similar again to our adults. It just may be that the time and type vary in the frequency and intensity. And of course, progression may need to go a little slower.